Okay, nursing care of the high-risk neonate. Let's talk about the babies that get sick. Okay, the gestational age classifications are interesting and important to learn. AGA is average for gestational age, and it means exactly that. If you have a 7-pounder at 40 weeks, that's average for gestational age. If you have a 5-pounder at 35 weeks, that little baby is average for gestational age, even though he's only 5 pounds. But if you have a 40-weeker who has a 5-pound baby, they are small for gestational age because by 40 weeks they should be bigger than 5 pounds. So it's important to know what gestational age a baby is in addition to their weight in order to determine if it's an average or a small or a large for gestational age infant. The SGAs run in the 10th percentile, lower than what an average weight should be. The large for gestational age, they in a high 10th percentile. They above that, those are their 9-pounders and up. IUGR is intrauterine growth restriction, and we talked about that when we talked about fetal monitoring, about what can cause intrauterine growth restriction, what decreases oxygen flow through the placenta that would contribute to that. And you should know some of those causes. And of course, high blood pressure is one of them. Mom smoking is another. So anything that's going to decrease oxygenation through that to that baby long term is going to cause IUGR. And long term, okay? There's also symmetrical versus asymmetrical SGA, small for gestational age. And what that means is the whole baby small, or is it just the head that's small? Okay, so you'll have babies that have abnormally small heads and their bodies are normal, and that is a problem with CNS development, which you'll learn as we go through the slides, what can cause that. Your symmetrical IUGR, those are the babies that have been chronically low on oxygen or nutrition of some sort for some reason, and they've symmetrically grown small versus just the head. What are some of the causes for an infant to be IUGR at birth? And I mentioned hypertension and smoking. Can you think of other ones? Here are some. Congenital malformations can cause that. Chromosomal abnormalities or anomalies. Fetal infections such as rubella and cytomegalovirus. That poor placental function, which we mentioned with the hypertension, and illness in the mom. What illnesses in the mom can cause that? Think of chronic hypertension, right? Maternal behaviors, that's where the smoking comes in. Also, drug use. And prematurity. Babies that are born early will be small, of course. What are the implications for the newborn? What is it we have to worry about in these babies? Well, it depends on the cause of the IUGR. However, universally, these are the complications that we need to watch for closely in these babies. And it would be hypoglycemia, which is low blood sugar. Hyperbilirubinemia, which is elevated bilirubin because the liver cannot handle, the little tiny liver cannot handle the blood breakdown. Respiratory distress and asphyxia, because the lungs are not mature. Cold stress. MAS is Meconium aspiration syndrome, where they've inhaled some of that Meconium fluid. They will have low APGAR scores, polycythemia, feeding difficulties. They have a hard time sucking and swallowing. They're not coordinated. So they'll gag and have a hard time. Hypoglycemia is, etiology is the loss of placental support, and the placenta will age. So it decreases that amount of blood sugar, of sugars available. Glycogen depletion, as that placenta ages, it just doesn't have the glycogen available. So those babies will get hypoglycemic. What they look like, they get very jittery. That's the biggest symptom of hypoglycemia, is jitteriness. They will have a high-pitched or weak cry. They'll be very lethargic and very little muscle tone. They just don't respond well. The treatment is to feed them. Start their feeding. Hopefully they can suck and swallow, and we can have them nurse with mama Supplement with formula if we need to get that blood sugar up more than what mama can provide initially. If the baby cannot suck or swallow well, then we would do IV glucose, okay? And just get them IV sugar in there. We got to get those blood sugars, blood glucoses up over 40, or we're going to have a neurologically impaired baby. If we treat it, there's no sequelae. So anytime you have a newborn that's got the jitteries and they're just flaccid and don't respond well, do a blood sugar. You don't need a doctor's order to do a blood glucose. And the way we do them is a heel stick. We do not poke baby fingers, okay? In the adult, we do finger sticks. Well, in a newborn, we do a heel stick. And we do not do the heel stick directly at the midline of the heel. You want to go off to the lateral side generally, or the medial side, but one side or the other to midline. You don't want to do midline because there's too much damage can be caused there. But hopefully you'll get a chance to do some heel sticks in the hospital. Birth injuries are those that are sustained during labor and birth, and they may be avoidable. Some of them are not. Ultrasound can show macrosomia, which is the big babies. It can show hydrocephalus, where you don't want to deliver a baby that's got hydrocephalus through the vagina because it will be, well, it probably wouldn't deliver because it probably wouldn't dilate. She wouldn't go. But if the ultrasound is showing hydrocephalus, they'd get a C-section. Any unusual presentations, so if they're breech first, then we would do a C-section. Elective C-section is chosen for some pregnancies to prevent the injuries. Prevention's always better than treatment. The nursing care management is to do a really good assessment. Check the clavicle, that's a big one, but you want to do a real thorough assessment of the infant, especially if they've had a tough delivery, tough time coming out. Of course, skeletal injuries, the clavicle is the most obvious one because those can break during the shoulder dystocia, and that's one of the types of injuries that if you got to have one, that's the one to have because that will heal quite readily if it is diagnosed properly and quickly. Also, there's a peripheral nervous system injuries. If there's been a lot of traction put on the baby's head and neck, they can end up with phrenic nerve paralysis. They may have facial nerve paralysis or herb palsy if there was a poorly done forceps delivery. And neurologic injuries, again, we have to really assess these babies well. Don't act like every baby is normal. You got to make sure that you're assessing for any concern. There is a small percentage of significant birth injuries that are unavoidable despite the best care. Someone's had a really difficult or prolonged labor and pushed forever and finally got the baby out, they can end up with one of those problems. That's why my personal belief is if there's a prolonged labor and it's been difficult, maybe we just need to do a C-section instead of try to, force something that's not supposed to be. But abnormal presentations, of course, if it's face presenting or which cannot deliver vaginally, it just can't. But breech babies, of course. Some injuries cannot be anticipated until the circumstances are encountered during childbirth, and that's just the nature of the beast. That's just sadly that's just the way it is. LGA infant is by definition the weight is over 4,000 grams, which is I think 9 pounds 2 ounces, somewhere around there. It's fetal macrosomia is another word for it, and the etiology of this is definitely a genetic predisposition to these. I had a patient who was this tiny little petite gal. She probably, without being pregnant, she probably weighed 102 pounds. So she's tiny. And she was married to a Dallas cowboy. And yes, this was in Atlanta. Their home base was here and he would commute, but he was a big guy. I mean, yeah, he's a football player, professional, big guy, and she's tiny. Yeah, she had a C-section. And she did very well. The baby was big, but everybody did fine. So yeah, when he went into the C-section, his feet were so big that the booties wouldn't fit, so we had to give him a surgical cap for each of his feet because they had to wear booties in the OR. Yeah, I don't know how he even fit. Never mind, I'm digressing. All right, multiparity. If they've had 2 or 3 babies before, they have a better chance of having a larger baby. In other words, seems to be each time you get pregnant, that next baby's going to be bigger than the one you had before. That is not 100% of the time true, but I've seen it happen. But then I've seen it go the other way too. But my kids was 7 pounds 5 ounces, and then my son was 10 pounds. So it was true for me. Males, interestingly, will often be macrosomic, more likely than females. And of course, the infants of diabetic mothers, they have that big puffy fat look. They're not healthy. The outcomes of these deliveries, there could be that birth trauma of shoulder dystocia. You get that fractured clavicle, as I mentioned. Could be a cephalohematoma or a subdermal hematoma or a skull fracture, as if that head has had a hard time getting through, or if they've had forceps delivery. Ocular hematomas, brachial plexus injury, as the traction put on the fetal head trying to get the shoulders out can cause that injury. There's an increase of C-section births in this size group, of course, and the infants are plump, full-faced, and they have immature reflexes. So they're big, but they're not mature. And they will get hypoglycemic because all that fat tissue will burn up all the glucose and then they bottom down. The infants of diabetic mothers have a very characteristic appearance of being macrosomic, and they're just big and fluffy, puffy. They don't look healthy. They, of course, have that increased risk for birth injury because of their size, and we must keep them warm, adequate thermal regulation, because we don't want to add cold stress to their problem because they will get even more hypoglycemic. Carbohydrate feedings as appropriate, and they need their glucose levels checked frequently to make sure they don't bottom out. And here is a fetal macrosomic diabetic mother baby. They're just fat, not healthy. He didn't even have a neck. Bless his little heart. They're so cute. This is a fractured clavicle. You can see that on x-ray there, and you would be able to feel that if you were to do a good a newborn assessment, which we expect you to do. You put your fingers on the clavicle and raise that arm up and down. You're going to feel that. You'll feel that click. But these, like I said, these will heal quite easily, quite well, actually, if they are discovered early. Here's a Bell's palsy due to a forceps delivery. Bless his little heart. This just makes me so sad. So sad. You see this? This is one forceps was here, and the other one, I'm guessing, was down here. This, the others, they have 2 forceps and squeezed together, and bless his little heart. This will resolve to some extent, but he will probably have trouble all his life with that. I don't think it's going to completely resolve. This dent in the head's got me concerned. My goodness. Oh, Blondie. Hyperbilirubinemia. This is due to RH or ABO incompatibilities. Will promote that. Infection will cause it. Liver abnormalities or immaturity certainly will cause hyperbilirubinemia if the liver's not working right. And hemolysis if there's excess amount of red blood cell breakdown. And that'll happen with bruising, any tissue trauma damage. The blood cells, the bruise, that will cause an increase in the need for the liver to break down these bad cells, but the liver can't do it because it's immature. Traumatic delivery and bruising, as I mentioned, hypoxia can contribute to that. Hyperglycemia, where because the bilirubin is displaced from the binding site, so you get the hyperglycemia, and then the breakdown of the red blood cells. As I said, the antibodies from the mom destroy the fetal blood cells, and if it causes excessive hemolysis, erythroblastosis fetalis occurs, and that is pretty much fatal. And this is due to the incompatibility, and that liver just cannot handle all the breakdown that it needs to do. And so the antibodies from the mom, this is the RH factor problem, and we'll talk a little bit more about that in a second. This is a little baby who had erythroblastosis fetalis. His blood type was, mom fought his blood all the way along and he just couldn't survive. You see he's yellow. Oh, so sad. So sad. Hyperbilirubinemia, you will see presence of jaundice in these babies. You'll suspect it and get a lab value and find out, yep, the bilirubin is elevated. The bilirubin, they may do them daily to make sure, because if it elevates greater than 5 milligrams a day, or if it reaches 12.9 in a term infant or 15 milligrams in a preterm infant, they have hyperbilirubinemia and they need to be treated. The treatment is quite simple, really. Phototherapy. They are under a photolight, a Billy light. And they lay under there with just a diaper on. It's warm, you know, we have a warmer on it, but the little diaper on, and they have their little eye shield on, and they just lay there, letting the lights pull out the bilirubin out of the skin. They also have serial bilirubin levels done to make sure we're headed in the correct direction downward. And the sequelae is nothing unless the bilirubin is not controlled. So early identification is key. Blood incompatibility, we talked about the RH before. That's where the RH positive offspring of an RH negative mom, they're the ones at risk. If the fetus is RH positive and the mom is RH negative, the mom forms antibodies against the fetal blood cells. And this is a good little picture of that. And it happens in the second pregnancy. That's where the problem will happen. The setup for the problem happens in the first pregnancy. We've got an RH negative mom, and this little baby in here is RH positive. And I showed you a picture of the placenta in a previous video that just shows you how close all those little arteries, maternal and fetal arteries and vessels are so close together that there's a high likelihood of some intermingling of the two. And if that happens, then mama is going to see these positive things as not belonging to her. She's not supposed to have anything there, but she does, so she creates antibodies. This baby will be fine. He's not going to be sensitized. The sensitization is occurring, but he is okay. He or she is okay. Well, between this moment and the next pregnancy, mom is still making more antibodies because she's, you know, and so she's got a lot of antibodies in her blood. Now this little positive baby in here, as the blood mingles, guess what? The antibodies cross back to the baby and fight the baby's blood throughout the rest of the pregnancy. That's when you get the erythroblastosis fetalis. Treatment for this is intrauterine blood transfusion. Let's just get this baby all started all over with unadulterated blood. And after delivery, they may get a newborn blood transfusion if they still need it. ABO is another part of the blood components that can cause incompatibility issues. It is not as severe as the RH, okay? But if the mom has O blood type, that means she has absence of anything of this stuff in her. It's zero. Oh, nothing here. And if the baby has an A, B, or AB, then again, the mom's body will recognize this AB or AB as not belonging there, and so she's going to make anti-A and anti-B antibodies. Now, it's not as severe as the RH one, but these babies still could require an exchanged transfusion. Prevention is to administer the ROGAM for the RH factor 1, and as I mentioned, transfusions may happen, and treat the jaundice. Newborn immune adaptation, IgGs, IgMs, and IgAs, and LMNOPs. What does it all mean? Immune system made easy. You're going to remember this for the rest of your life. IgGs indicate a prior infection. They are not a current problem. Think of them as, gee, I'm glad you're here because they have helped you in the past. They are great to have because they help you now. They prevent. So they're in the past. They come through the placenta from the mother to help her newborn. IgMs, my, oh my, there is something new here. These do not cross the placenta because these molecules are too large. So my, oh my, the newborn must have been exposed to a current existing intrauterine infection that is not good, okay? Some IgM in the neonate is normal as the newborn is exposed to normal environmental antigens after birth. But if you have concern about an infection, we would do an IgM titer to see if it's a current infection the baby is fighting. Then there's the IgAs. These are the airway and abdominal protectors. These do not cross the placenta. They must be made by the newborn. And this is why newborns are at a higher risk for respiratory and GI infections. But guess what's in the colostrum and breast milk? IgAs. So you may have heard how babies that are breastfed have fewer respiratory and fewer GI infections than bottle-fed babies. This is why. They have IgA getting in the breast milk. The epidemiology of neonatal infections. 1 to 8 bacterial infections are in about 1,000 live term births. There are 160 to 300 per 1,000 live very low birth weight infants. So those very low birth weight infants have a 20 to 40 times greater risk of having an infection. In the United States, the biggest problem is group B strep. Women are tested for group B strep when they're about 35 weeks pregnant. It is just a vaginal swab, goes in the cervix, and they just swab the area with a Q-tip type thing. And if they're group B strep positive, the goal is to have her receive penicillin at least 2 doses, 4 hours apart, when she's in labor. And that will prevent transmission of group B strep to the neonate. So if we have a patient who comes in and she's group B strep positive, you better believe we're going to get that IV in her and bag number 1 of penicillin, which is the drug of choice, penicillin in her as soon as we can, and then we get the second dose in 4 hours later. If she is really close to delivery and we're concerned that we might not make it for 4 hours, then we'll hang it 30 minutes early because the goal is to get 2 doses in. That is the best way of protecting the baby. If they're allergic to penicillin, we use clindamycin. It is not as effective, so those babies will still need to be tested for infection, but they're probably going to be fine. Now, interestingly, worldwide, what infections are out there? E. coli, 25 to 45% of infants in the world have E. coli infections. And yeah, so we all know where that comes from. And I would think good hand washing and hygiene would help. Streptococcal infections, 11 to 14%. CMV is cytomegalovirus. There's 10 per 1,000 births. And other viral infections are herpes, varicella or rubella, chickenpox, varicella or chickenpox, and then toxoplasmosis, which is the cat litter one per 1,000 births. The signs of neonatal infection would be temperature control issues. They either have a fever or they're hypothermic. They're really cold, really hot. You're going to see some respiratory issues such as grunting, retractions, cyanosis, apnea, and tachypnea. And in class, I'm going to show you some videos of those different breathing, the grunting and retractions anyway. Cardiovascular, they'll have tachycardia. A newborn's heart rate should be regular, should be a nice regular rhythm, but in an infection, a baby with an infection, they will have dysrhythmias. They may have hyper or hypotension, cold, clammy skin, and decreased peripheral perfusion. The will display some neural problems. You might as well memorize these because this happens in a lot of babies. This is a lot of with central nervous system problems, lethargy, irritability, seizures, hypo or hypertonia. They're either very flaccid or they're very tight. Bulging fontanelles and high-pitched cry. That's very typical of central nervous system problems. Torch is a titer that we do on women who are at high risk for any of these. Someone who has a cat with cat litter, we would do toxoplasmosis screen on them. any of these are really bad, okay, on a neonate. So we're going to talk about them in a minute. But so the torch is toxoplasmosis, rubella, cytomegalovirus, and herpes. Toxoplasmosis is the cat box litter one. It can result in stillbirth, severe anomalies, deafness, seizures, or coma. It's bad. All of these are bad. It is so bad that they recommend a therapeutic abortion prior to 20 weeks if there's toxoplasmosis positive. The babies are just not going to make it. They are given anti-infectives after 20 weeks to help prevent infection, and there is a 40% newborn infection rate for moms that are positive for toxoplasmosis. 40% of those babies will have it. Rubella is a chronic viral infection, and its greatest risk is in that first trimester. As I mentioned before, between 5-6 weeks and 9 weeks, that's when all the organogenesis is happening. And so that's when there's the greatest risk of damage. Congenital heart disease would be big because, that's what's forming in those early weeks. Intrauterine growth restriction can happen. Cataracts, interestingly, mental retardation, hearing impairment. It's vital that, again, that therapeutic abortion is recommended to these moms as well in that first trimester. Prevention is immunization with a rubella vaccine. The prevention is pretty simple, but we don't want them pregnant when we give that. So if she is coming in for a prenatal visit prior to getting pregnant, this would be one of the things we want to make sure that she has received before she gets pregnant. We recommend that they don't get pregnant for at least a month after getting a rubella vaccine. So what I used to tell my patients was 3 months, because if I tell them 3 months, don't get pregnant, they're probably going to at least behave for the first month. Human behavior being what it is. Cytomegalovirus is a herpes virus. It eventually will affect most humans. It is the most common of the viral infections in the fetuses. About half of them, if the mom's affected, about half those babies will have it. It results in mental retardation and CNS abnormalities, can result in problems with eyes, ears, IUGR, blueberry muffin syndrome. Antivirals, they're questioned whether or not they help, and hand washing is key. Just make sure good hand washing for life. Herpes virus type 2 is another concern. There's it's called vertical transmission. Once the rupture of membranes. Once the water has broken, then herpes that is located in the vaginal or perineal area can transmit upward into the sterile uterine environment and infect the baby that way. So as long as the water bag's intact, these babies are protected. But once their water bag breaks, those babies need to be delivered by C-section within 2 hours. That's the guideline for having a non-affected baby, is the 2 hours post-rupture. So if someone, it's important to teach these patients when they're pregnant, if your water breaks, call me right away. We need to have that baby born by C-section within 2 hours. Okay. Now we do give these patients acyclovir in the last month to prevent, have a better chance of preventing her having herpes at the time she goes into labor. Babies that are born with herpes virus, they may be asymptomatic for the first 2 days to 2 weeks about. They do have an increased risk of spontaneous abortions, IUGRs, and preterm labors. They could have skin lesions, most likely. It may become a systemic infection, and 50% of those babies will not make it. This is a picture of a baby with blueberry muffin syndrome, and you can see why it's called blueberry muffin. Interesting. Didn't you wonder why people come up with names like they do? Anyway. All right, HIV inserts itself into the genetic makeup of the cells, thus affecting that cell's ability to perform normally. Then this cell replicates and creates more of the same. So it's one of those that just generates itself. Once it's there, it just keeps on going. The biggest effect is on the immune system, and newborns already have an immature immune system at birth. Transmission is lessened with antiviral treatment during pregnancy. So fortunately, we do have methods to decrease the risk of that for these newborns. These moms will not be breastfeeding because HIV does go through the breast milk. The babies will get postnatal treatment of the antiviral treatment as well. Symptoms in the newborn, they may be asymptomatic at birth, but the symptoms may develop in the first year of life. And they're related to infections, such as enlargement of the spleen, liver, spleen, liver, lymphadenopathy, their failure to thrive. They have persistent thrush. The yeast is real common in HIV patients, so these babies would have that. Persistent cradle cap. They constantly have the skin breakdown and other more serious systemic bacterial infections such as meningitis, pneumonia, osteomyelitis, septic arthritis, and septicemia. They're very sick. So fortunately, we are able to prevent a lot of that with the antivirals. This is a really preterm baby. Look at how his neck is like so tiny, and the wrinkled skin, little tiny fingers. Oh. Respiratory distress syndrome, RDS. We're going to be talking about a lot of breathing syndromes here. RDS is due to lung immaturity and underdevelopment. This is surfactant deficiency one. That's to prevent RDS. We give mamas steroids when they're pregnant if we are concerned about preterm delivery, so we can avoid this problem. The risk factors are pregnancies that deliver before 30 weeks, babies that are less than 1,200 grams size, the preterm, of course, C-section deliveries. Okay, it might be a full term, but why is a C-section delivery at risk for the RDS? It doesn't have the vaginal squeeze, right? The tight fit through the vagina causes fluid squeezing out of the lungs. They're less likely to have RDS. Moms with diabetes, their babies are at greater risk. The symptoms, signs and symptoms are the grunting, flaring, retracting. We'll see little videos on that. Fatigue leading to apnea. They will show signs of hypoxia, just kind of bluish color. And on X-ray, you'll see the radiographic changes, which is basically the whiteout. You'll see how the lungs are filled. This is an interesting fact that I wouldn't tell patients, but I want to tell you guys. Babies who are subjected to chronic stress while in utero, those whose moms were heroin addicts, they have preeclampsia, IUGR, premature rupture of membranes, or if they smoke, they have an increased surfactant production and the lungs mature more quickly, basically because they are trying to live. So if you have a 28-weeker of a heroin addict, that baby may actually do better than a 28-weeker of someone who hasn't done any of these behaviors because the lungs were forced to grow up faster. It's not recommended to do that though, okay? Just make that clear. RDS, the treatment, oxygen and PEEP, positive end expiratory pressure. Exogenous surfactant, they've been trying to, they do try that to see if they can increase surfactant by actually putting it there. And then nutritional support. And the sequelae on these babies can be bronchopulmonary dysplasia. So we're trying to avoid that by getting them better quick. Fix the problem quick. Transient, keyword, tachypnea of the newborn, TTN. This is the wet lung. This is the type 2 RDS, and this is due to delayed absorption of fetal lung fluid, which is due to the lack of that chest compression at delivery. That's why your C-section baby is a risk. It is the risk factor for that because they're not getting that chest compression to push the fluid out of the lung. It lasts about 48 hours. The best thing that these babies can do is cough, cry, cough, and cry. Okay, just get that stuff out of there. Risk factors besides the C-section would be if the mom had asthma or is a smoker, diabetic. The IUGR infants are at greater risk, and precipitous deliveries, which we have not yet talked about at all, I don't believe. But a precipitous delivery is one that happens so fast that nobody has time to be ready. Okay, The mom comes in, or she might have been there, and the baby is just, she goes from from hardly being in labor to bam, that baby's out. It's flew through the vaginal canal and nobody had time to be ready. Or if you did, you barely had time to be ready. And those babies don't have that time in the vaginal area to have that chest compressed. So it kind of, even though they deliver vaginally, it happens so fast, they don't get that squeeze to get the fluid out of the lungs. Now the bronchopulmonary dysplasia, or BPD, it turns into, it's this chronic lung disease. This is due to a prolonged mechanical ventilation, and babies that have been on a ventilator for a long time, or if they have been on oxygen longer than one would expect, they're probably going to end up with chronic lung disease. You'll see them doing the air hunger thing, where they're literally trying to breathe, okay? I mean, you can see them struggling. And irritability, you know, low oxygen is going to make anybody irritable. The other symptom they can get is cor pulmonale, which is, it's a condition that usually comes from high blood pressure in the pulmonary arteries, pulmonary hypertension. And it's also known as right-sided heart failure because it occurs within the right ventricle of the heart. And it causes the right ventricle to enlarge, pump blood less effectively than it should, and the ventricle is then pushed to its limit basically, and it just fails. These babies don't do well. Perinatal asphyxia or intrauterine hypoxia, kind of meaning the same thing, not enough oxygen. The etiology can be prolonged cord compression. Now we fix that by changing maternal position, trying to get the baby off the cord, but chronic compression can cause that hypoxia. The more likely causation, though, is going to be that placenta. Remember from our fetal monitoring, what can cause diminished placental perfusion, and we've talked about that, you know, the hypertension, if the mom's a heavy smoker, anything that's going to cause a decrease in the oxygenated blood getting to the baby. Maternal hemorrhage, okay, that's going to lead to a loss of oxygen through the blood. I mean, she's bleeding it out. And then anemia, if mom's severely anemic, would be another reason. Signs and symptoms are going to be low APGAR scores at birth. You can tell they just didn't have much going on inside. We got them out and they're just, they lay there. They're hypertonic, hypotonia. They don't move. They don't fight you when you touch them. They have very slowed respiratory rate and a slowed heart rate, poor skin color, abnormal, really off arterial blood gases. Then we get to Meconium aspiration syndrome. MAS is how you'll see it written some places. And it's due to hypoxia in utero. Anytime when our oxygen level drops low enough, we poop. That's what happens when we die. Okay. So if the baby has been under enough stress in utero, it could be that the oxygen level will drop low enough that it poops, and that's the meconium. We see meconium in the fluid. Once the water breaks, we'll see meconium, so that's one of the symptoms. It comes out meconium stained fluid. X-ray will confirm that there's meconium aspirated into the lungs. We look by X-ray. This treatment of that for it is to suction the bulb suction definitely, but the endotrach suction, putting a tube down to suck it out. Nursing used to do that, but they took that task away from us because some nurses were a little overzealous about it, and if you suction too much, you're going to actually cause the baby to crash down. So they have respiratory therapy usually does that now, would be the ones that come to the delivery and get that stuff out of there. Our job is, of course, to assess the respiratory function, listen to those lung sounds. Can you hear which part of the lungs have less perfusion in them, less breath sounds in them? We would provide oxygen support, and the baby would be on antibiotics to prevent infection from that stuff in the lung, the pneumonia. And the sequelae may advance to persistent pulmonary hypertension if not properly treated. Most of them do okay, though. Tracheoesophageal fistula, TEF, and this is an abnormal connection between the trachea and the esophagus. So what's going to happen there? You got your breathing in your trachea and your esophagus, they're all mixed up. They're together. So they're gonna have the signs of RDS. They require more suctioning. They can't swallow that down into their stomach because there's no opening there. They may have frothy drooling because all that stuff's got to go somewhere, so it'll come out the mouth. The catheter will not pass into the stomach, and they will have choking, difficulty feeding, and the only treatment for that is surgery. Needs to be surgically fixed. They'll do okay. Preterm infants are those born before 37 weeks gestation. They have an immaturity of most of their organ systems. We don't know what causes one woman to go into preterm labor and another woman not to. We have no idea. It's just the way it is. And these preterm infants they're small and scrawny. You saw that little picture of that little early baby earlier. Very small, scrawny. They don't have any subcutaneous tissue or fat. They have their head appears larger than their body because just the way it grows. Translucent skin, very thin. You can see the blood vessels through the skin. And lanugo, of course, lots of hair, as they don't have the body fat to keep them warm, so they have that hair that will go away as it's closer to term. Intraventricular hemorrhage is one of the pathologies for the preterm infant, and the treatment for that is to monitor the oxygen and CO2 levels, platelets. Keep the stimulus low. These babies need to preserve energy so they can grow. So we don't like to disturb them too often. We don't want to be moving them here and there. Just leave them, turn them as necessary, but then let them rest. If they have seizures, they'll be on medications for that. Interestingly, with these preterm infants, they've found that babies that have been held by their mom or their dad, little tiny preemies, they do much better than babies that have never held. So I'm not saying hold and put them up and put them down, but holding and bonding, really they do a lot better. And also really cool, you have twins that are born preterm, you put them in the same crib next to each other, they'll do much better than if you separate them. The sequelae of the intraventricular hemorrhage depends on the extent of the bleed. They're grades 1 and 2, they do quite well. The 3 and 4, they could have long-term problems. Necrotizing enterocolitis, or NEC as we call it, this occurs due to immaturity of the gut in these preterm infants. And also the blood is shunted to vital organs and away from the gut in these little babies. So it's going to go where, the heart and lungs, brain, kidney, the gut's going to just get kind of bypassed because it doesn't seem important, but of course it is. NEC will increase in incidence after they receive feedings, and the symptoms are increasing abdominal girth. So in the NICU, they're measuring these babies' guts, their abdomen every day, every shift even. Distension, decrease or absent bowel sounds. If you ever get a chance to work at CHO or be at CHO, it's fascinating that what they do for these babies. The gut is definitely a major portion where we get our absorbed nutrients, right? Our food goes to our gut and it hangs around there for a certain amount of time and we absorb nutrients from that. Well, if you have a baby that has the gut's it's not letting things go in it, they're not getting those nutrients absorbed, okay? So these babies will end up with a colostomy, and the way that this is really quite weird, but the way they treat, you wonder who does this for the first time. So let's try this. But anyway, the way they treat it, they collect the colostomy product, and they put that in a syringe, a 20 milliliter syringe, and hook it up to a pump, an infusion pump, and they pump it back into the gut. It looks to your eye like you've got an IV of poop headed to the baby, but it's not in the IV. It's not in the vein. It's in the gut. But it's the strangest thing to walk in there and see poop on a pump, okay? I mean, that's just all I'm going to say. But there is definitely reason to do it because the gut will absorb things and provides acid in certain levels, and if that all gets bypassed, then we lose the ability to have the benefit of our food. So they put it back in there so that the gut is still able to work with its own stuff, its own mucus, its own breakdown products. Anyway, I probably didn't explain that well, but it's pretty cool. Other problems with premature babies, preterms, are going to be your pneumothorax, the chronic lung disease again. Retinopathy of prematurity, that is an interesting one that fortunately they've minimized that happening by changing the way they do oxygenation. In old days, in the good old days, they used to put the babies, of course, were on oxygen because they needed it, but they were on too high of a level, and these babies would end up with retinopathy and blindness. So now they've come out with the ECMO and then like the little butterfly machines, which provides the higher level of oxygenation, but not at the pressures that it had to be at in the good old days. So we're preventing a lot of that problem now. And then, of course, neck is potential complication with these preterms, preemies. What's really sad, we get these babies that we deliver at, 26 weeks, and we feel so proud that we saved their lives. And then so often the parents end up living in the unit at CHOA because their babies have neck, and they just, they have colostomy bags. And yeah, we have to save babies, but sometimes I wonder what we're saving. My goodness. The retinopathy can be discovered only by ophthalmic exam. The diagnosis is retinal changes that occur due to those fluctuating oxygen levels, which have caused constrict, dilate, and damage the fragile vessels. And so the treatment is to monitor their oxygen levels, use that, just be careful with that, and then the cryo or laser surgery to maybe improve the vision. Okay, now we're going to talk about the big guy on the other end, the postterm infant. These are the ones the gestation extends beyond 42 weeks, and this is up to about 15% of pregnancies will go to beyond their due date, to 42 weeks and beyond. It's really weird. You wonder sometimes if we never induce these people, would they ever go into labor? I mean, how many weeks would they stay pregnant before their labor decided to happen? You really kind of wonder. But sometimes they have 15% of them have to be induced because they just don't seem to ever want to go into labor. The placenta will start getting old in these pregnancies, and that's why it could be a placental dysfunction. That's what this is for. Since we don't know what starts labor, we don't know what starts labor. We don't know what doesn't start it. Okay. Whether it's a placental issue, the placenta's not doing something it's supposed to do, we just don't know. We don't. But there's an increased risk for birth injuries because of them being postdates and bigger. The definition, as I said, born after 42 weeks, regardless of their birth weight, and the placenta will age and get placental issues such as infarcts and calcifications. And it's truly what they look like, little white calcifications on there. It's like not teeth, but it's that kind, it's hard like that. It'll calcify and the baby will die. These babies are at risk for Meconium aspiration syndrome because they're at risk for Meconium. Placental insufficiency that just says, I'm done. And, mom's at the supermarket, the placenta stopped working. Good Lord. Hypoxia, hypoglycemia, the polycythemia, seizures, and cold stress. All of those are potential risk factors, potential things the baby will have to deal with. Physical signs are really, really dry, cracked skin. They have depleted sub-Q fat, so they actually start. They're not pretty. Okay, they're just not. They're often meconium stained because they pooped. So you've got this really dry, cracked skin baby that's now all brown, and it's hard to wash off. See, here's a little meconium stained post-dates hand. See the cracking and peeling, and then now imagine this baby's had a bath. Okay, this is after a bath. Imagine at time of delivery. If this brown here is that meconium stain, imagine it all over the baby in these cracks. It's hard to get it out. It's not pretty. It's just not. These poor little babies. Oh, sigh. And you see the feet have a lot of creases to them. Now, when you're doing a Dubowitz gestational age assessment, if you're lucky enough to do one of those on babies, or at least use the tool in the Sim Lab or Skills Lab, one of the things you look at is the amount of creases on the feet, on the soles of the feet. And these are really a lot of creases, okay? This is post-dates because there's so many creases. This is, you see all the dry cracked skin. He doesn't look like he had meconium though. I don't think this guy had meconium, but all that dry crack, and realize every time there's a dry cracked skin, there's a portal of entry for bacteria. So these babies have a risk of skin infections. You can see why that's possible. All right, now we're going to screen our newborns for diseases. There are things called inborn errors of metabolism, which is a fancy way of saying the baby that lacks these abilities to break things down. And so they end up with long-term potential problems if we don't know about it. Congenital hypothyroidism, of course, is one. And then PKU, phenylketonuria, that's the one they test for in the nurseries before they go home. Babies have to have had nutrition, breast milk or formula for 48 hours prior to getting this done for it to be accurate, because they need to see if the protein has been able to break down the formula or the milk. If the ideal is that these parents know before they get pregnant or early pregnancy that there is a risk factor. It's a recessive trait. I think it tells us on the next slide. Yes, PKU is a disease of protein metabolism. It's an inborn metabolic error, autosomal recessive trait. So these require both parents to have the trait for the baby to actually have the disease, and it would be a 25% risk of the baby getting it. So hopefully the parents have had genetic counseling and are aware of this, so that we test every baby, so it isn't like we would miss it anymore. But if we did miss it, it would cause central nervous system damage from toxic levels of phenylalanine in the blood. And what these babies, how they treat it is they are on a phenylalanine-free diet so that it doesn't cause damage. So it requires a huge transformation of the parents, their, what they feed their child, what the child's able to eat, but it's at least treatable. It takes a lot of learning though. The incidence in the US is anywhere from 1 to 10,000 to 1 to 25,000 live births. And that's besides PKU, these Guthrie tests also, there's 6 circles. There might even be more now since I was in the nursery, but there are 6 circles that get filled with newborn blood, and it's done by heel stick. Okay. And if you're in the nursery, you'll be able to see them, watch the nurses do them, and you might even be able to do them yourself if they want to work with you enough. And if you're a precepted situation, you'd eventually be able to do them. But the test not only for the PKU, but it's several different things, which I don't know all of them. But it tests for a lot of those inborn errors, not just one. And then there's fetal alcohol syndrome. Oh my goodness, just know that if you're drinking, the baby's drinking. All right, these moms need to know that if you're drinking, the baby's drinking. Alcohol readily passes through the placenta. The concentrations in the fetus are going to be at least as high as that in the mother. In the first trimester, again, we're causing structural defects, right? That's when all the organogenesis is happening. In the third trimester, heavy drinking will cause central nervous system is the most vulnerable system, because the brain is rapidly growing then, so that's going to be what's affected. If they drink throughout the entire pregnancy, it interferes with the transfer of nutrients and retards cell growth and division. So they're sick. Fetal alcohol syndrome is the leading cause of mental retardation and the only cause that is preventable. These babies have very distinct facial features, which we'll have a little show in a minute. They will have prenatal and postnatal growth restriction and microcephaly. If you remember at the very beginning of this, I talked about asymmetrical growth. This is an example of that, where the body will grow okay, but the head is small. Asymmetrical growth, and it's due to the constant assault by alcohol. The central nervous system impairment will result in learning disabilities, ADHD, ADD, and poor short-term memory. And now think about this. You've got a child with some really long-term learning disability that's going to need special care that way, and it's going home with an alcoholic mother. So, yeah, Not a good combination. The assessment findings in the neonatal period are going to be those same ones we've been talking about. RDS, irritability, lethargy, seizure activity, tremors, poor sucking, abdominal distension. They're very uncoordinated type sucking. This is just a drawing or a picture of typical things to look for. They're going to have a flattened nasal bridge here. They have a tipped up nose. This is interesting, this railroad track ears. I've never seen that on anybody, but I see them on him. Thin upper lip. It's very thin there. Smooth here. There's no creasing or cellular. It's just real smooth philtrum, which I would never remember that word. I'm glad they had it written out there. Okay, these are pictures of fetal alcohol syndrome children. You see the flattened nose, smooth. See that? Oh, and he doesn't have railroad track ears, but his ears are funny looking. Poor little babies. The drug-addicted neonate. Oh my goodness. The signs and symptoms are listed in your book, but basically these infants are jittery, extremely difficult to soothe. They are poor feeders and poor suckers. They are hyperreflexic. They just, a little bit they'll jump like crazy. They're easily irritated, and they are IUGR. The treatment is focused on comforting the infant and maintaining nutritional status. And we must provide constant attention to their respiratory status and protect them during seizures. They will not be breastfeeding. They do not need any more exposure to drugs, and they are truly the saddest of the sad. Just something to think about. And if we were in class, we may have discussed it, and we might discuss it on Friday. But how do you feel about these babies going home with their moms? Okay. You know, the goal is always family reunification, but how do you feel about that? How do you feel about promoting bonding? Do you want the mom to come in? How would you handle her when she comes in? Are you going to be able to be a, professional and objective and kind and caring? That's what we would need to be, even though we were kind of inside us, kind of mad that this baby has to go through this, because they're not easy to take care of. I'm sitting here talking to you at a computer, but these babies are very difficult to take care of. They are not fun to take care of because they're so irritable, but your heart breaks. Your heart absolutely breaks. And this parent, this mother, and I don't know where the dad is. We're not even talking about him, but these moms have their own issues, and now they were going to take home a baby that has a lot of issues. I don't know. In pediatrics, you'll have similar challenges when you care for a child who's been abused. How are you going to feel when the parent shows up to see the baby, if they're allowed to? Birthmarks, the Mongolian spots. Those are bluish black marks. They resemble bruises. They're usually in the sacral area, but also can be in the buttocks, arms, and shoulders. They occur most often in the dark skin populations. We'll see them in the African American population, Hispanic, and Asian. They usually disappear with time. What's important about them is to document them, because if for any reason this parent had to take that child to an ER, a couple months down the road for some really legitimate reason, and they saw this, they could think that this was abuse. This could look like they abused this arm. So if we have documentation that the size of the Mongolian spot, where it's located, then that protects that family from being accused of abusing their child. Okay, they can go back to the records and say, no, that's from birth. Okay, because they look like a bruise. All right. Navis simplex, aka also known as salmon patch or stork bite. And I'm not even going to try to say that word, the other one. But they are flat, pink or reddish discoloration from dilated capillaries. And they occur over the eyelids, above the bridge of the nose, the nape of the neck. The color will blanch when it's pressed because it's dilated capillary, so it'll blanch. And when the baby cries, it'll get redder because it's a capillary. And they usually disappear by a couple of years. Here's a stork bite here. And if the mom's concerned, you tell her, very normal. A lot of babies have them. Stork bite. Navis phlemis, or port wine stain. These are permanent. They're flat, dark, reddish purple mark. They may not blanch at all. Okay, that's because they're not capillary origin. It's actual skin discoloration. They vary in size and location, and they can be removed by laser. If you see these port wine stain around the forehead and upper eyelid, it could be Sturge-Weber syndrome, which is a serious neurological condition that may also involve eye problems. So again, it's important to document where we see all these birthmarks. And if you don't know what to call something, describe it. Flat, red, goes across the mid of the back all the way to the front, however you want to, but these are port wine stains. I've seen them on the face, several people on the face. Strawberry hemangioma. These are enlarged capillaries in the outer layers of skin. They are dark red and raised with a rough surface, and they're usually located on the head. They might grow larger for about 5 or 6 months, but then they usually disappear by the time they go to school, and no treatment is necessary. And this is a hemangioma, it's a little small one. This one, I'm looking at that going, what in the world? That's huge. I don't know that that would self-resolve. I don't know. I'd be worried if I was that mom. Cafe au lait spots, these are light brown areas, and they can occur anywhere on the body. They're usually harmless, but number and size are important. If the baby has 6 or more spots that are larger than a ½ centimeter, or spots that are larger than a ½ centimeter, they may be associated with neurofibromatosis, which is a genetic condition of the neural tissue. So document how many. It's important to really pay attention. And basically, this is the typical, what I always call, I have one. I'm not going to tell you where, but I have one. But it's a birthmark. And there are no biggies. And we are done. We hit the last slide. So there we go. Have a good day. Good day.